So this is also a continuation of a project that we started a few years ago where we're looking at delivering antibody-based therapy to HER2-positive breast cancer lines. Previously we looked at delivering Herceptin to the BT474 model, which was a sample from a patient not in their brain met. So here we're looking at two different antibodies, and we're using a model which we think is maybe better. There was a model that was obtained from a patient's brain metastasis. I don't know if I have to highlight the problem of breast cancer, but breast mets occur in 10 to 30% of patients, and between 30 and 50% of them are HER2 positive breast cancer patients. There's two antibody therapies that target our HER2 receptor that are available, and typically when the patients, while these drugs are effective in controlling tumor growth, when they get to the brain, they are less effective. And the thinking is because of the blood tumor barrier, which is partially leaky, but it's still restricting how much drug we can get to the brain. So we think we can overcome this with using ultrasound to further disrupt the blood tumor barrier and maybe some margin around it also. All right, so here we used this earlier when we delivered Herceptin to the normal brain in earlier studies when Kalerva was at Brigham, and then we also did this in the earlier model showing a strong treatment response in some of the animals where we gave Herceptin to the other models. Here we're looking at a better model. This is the MDA MB361, and these were injected into the right brain of nude rats. We did not do the carotid injections. We tried to do that. We couldn't get that to work, so we did a direct injection here. But we still think this is a better model than what we were working with before. And then we evaluated tumor growth with T2 weighted imaging every other week until the tumor was a few millimeters, and then we began treatment. Before we started, we looked at this in cell cultures, and we can see that this is not the strongest response to Herceptin and pertuzumab, but in combination that there is an effect that probably mimics what we see in a lot of patients. So we had 3 different treatment groups with 10 animals, and we did 6 treatments weekly under MRI guidance, starting between week and 10, and then we followed those out until they were sacrificed. We used this in our Brooker system that we built using Optoson microbubbles, 690 kilohertz ultrasound, using parameters that we wanted, that we've used in the past, and we tailored the number of sonications depending on the size of the tumor. Before the sonications in the animals that we looked at, we found that at the early stage of these, at least, these were actually not enhancing in contrast-enhanced MRI before we applied ultrasound, but they were after we applied ultrasound. So this is an example of that. Here we see, before ultrasound, we see some enhancement, but when we apply the ultrasound, we get a higher enhancement and also enhancement in the surrounding normal brain. We measured their growth rate over the period during and after the treatment, and we identified what we are calling a responder, where the animal has a growth rate that's less than the mean of the controls minus 2 standard deviations. And you'll see the reason why we did that. And then at the end point, if the tumor exceeded a certain size or the condition was poor, we sacrificed the animals. We also looked at some histology. We did some HER2 staining way after the treatments just to confirm that these were HER2 overexpressing. And we can see here, these are the growth rate curves. And in the animals that we did see a response, we did see during treatment, we did see a deviation from the growth of all of the control animals. But it was only in about 4 out of the 10 animals. And after the treatment stopped, the growth was resumed. None of the controls or the antibody animal-only groups responded. And we saw no other responders that occurred during the follow-up. follow-up period. So we believe we are able to induce suppression of the growth rate using MR-guided focused ultrasound, but this is, again, it's slowing the rate, and we need to figure out why it's only in a portion of the tumors. And again, like I said, that these were not leaky tumors before disruption, and all of the disruptions were successful. We didn't find any imaging evidence of why we had some responders and other non-responders. And this result was actually similar to what we saw earlier with Herceptin, and also from a paper from the Sunnybrook group who looked at HER2 positive, doing natural killer cell therapy. They also saw a similar proportion of responders and non-responders. So this is something that we will hopefully can figure out, and this is what we're looking at now. And again, we didn't see any obvious reasons why we saw the tumor volume at the start of the treatment was the same. We looked at the HER2 expression. We didn't see any difference or the contrast enhancement. So from this, we can conclude that we do need to disrupt the barrier for drug delivery. The no responders, and we may have to, if this mimics what we have in patients, we may have to continue treatment for a long time. But we did show that we can use FUS BBB opening with antibodies to slow growth rate in breast cancer brain mets. So thank you.
Thank you, Nathan. Yes?
Just a quick question. One of the major mechanisms by which Herceptin works is by antibody-dependent cellular cytotoxicity. So natural killer cells, macrophages get in there. Did you get a chance to explore whether those parameters changed?
No, we have not. We haven't looked at that. So here we were primarily doing a survival study, so by the time we got to look at the histology, it was months after the treatment. So.
So you showed you had a decelerated growth rate during your treatment, but it appears then after you stopped the treatment, the growth rate actually accelerated compared to your controls. Do you have any explanation for that?
I'd have to go back and look to see if that was the case or if it's an artifact of the graph, but I don't have an explanation on why that might be.
Thank you.
Nice talk, Nathan. The MB231 cell line can be done intracardiac, and you see multiple mets. Have you looked at the possibility of treating one met and seeing the effects in other mets in the brain?
So we tried it in the nude rats. We actually did carotid injections. We actually got the line from Texas that was made to be brain homing. And we didn't have very good luck with it, and we concluded that we probably need to go back and use a nude mouse like other people do. But we were working with rat models at the time, so we went back to the intracranial model. But that is something I really want to do. One of the issues with it is that we have to figure out how we can tell if it's, if they have systemic mets, how do we help, whether we improve survival, is it from the brain mets or not the brain mets?
Actually, there's a BRL line. So there's a luciferase positive line that's a brain only, although it does go to the bone, that we've published on. And it actually, with an intracardiac injection, will distribute throughout the brain, through the brain as well as into the bone. And you can track them because if you label them with iron oxide, you can find them in the brain.
I believe that. I agree that it's probably a better model to look at in the end. But here we were just focusing on the effect on the brain met itself. Great. Thank you. Oh, I'm running a bit late, so quick.
Quick question. It seems like you have to first find the region where the tumor is before you can apply the ultrasound, but then you can't see the tumor because you can't get contrast in there. So how do you? You
could see the tumor in T2.
In the T2.
The stage we were looking at, yeah.
Okay.